Артем, бәрін тұртыр. Бұл катетер. Можно? Так, ана жерге тиіп кетпейсіздер ғой? Хорошо. Мынаның бәрі стерильно, тиіп кетпейсіздер ғой? Жень, как звук будет, скажете? Hello, dear colleagues. How are you? My name is Mynzhylky Berdikhojayev, and with my colleague, neurosurgeon and assistant Abzal Kairatlı, we are from Almaty, Kazakhstan. It's a national hospital of the Presidential Affair Medical Center of the Republic of Kazakhstan. And today in our Andrew Suite we have colleagues from the national TV channel, Kazakhstan. And they are doing TV project. The project name is TV Doctor. And today we have patient just 67 years old female with incidental finding. She had a blindness on the left side, and on right side she has a hemianopia. That's why our colleagues ophthalmologists started a diagnostic algorithm and on MR. The big aneurysm of the left ICA was found, and she was sent for the consultation, and we planned for the embolization. And let's see the imaging. This is a left ICA aneurysm, and on the left side we have two aneurysms. One aneurysm before the entry to the big aneurysm, it's a small one. And also patient has one more aneurysm on the right MCA territory. Okay, let's check. Сосын экранды тартып жібересіз ғой, бақыт, хорошо. The diagnostic angiography from the right side, vertebral system is normal, and venous system is also okay. There is an infundibulum on right ICA and the MCA bifurcation. Through the angiography, you can see the aneurysm on the MCA bifurcation. This aneurysm we will schedule for the second session. Usually it's in a couple of months after first session. Let's see how she will proceed after first session. Left vertebral territory is normal, and patient has small tortuosity on the cervical ICA before the petrosal segment. Time to time I will switch for the Kazakh language because channel is national, and I need to comment on Kazakh for our population. And okay, this is a 2D imaging. Aneurysm is 22.5 millimeter, 17 millimeter width, and wide neck. Distal ICA is 3.9 millimeter, proximal is nearly 4 millimeter. And we discussed this patient with Abzal, and I think the Fred stent 4.5-34 will be better. And the problem is navigation. Okay, this is a 3D, and you can see on only 3D we can see this small aneurysm on proximal part, and the angulation is more than 90 degrees. Just a second. Yes, you can see this angulation, the entry to the aneurysm, and the exit. It's more than 90 degrees, and it's also visible on 3D. This angulation is 90 degrees. And our access is 8 French introducer schist, short one. And then we took Neuromax 6 French, and for the access inside the Neuromax we put 6 French coronary guiding. And now we will switch 6 French coronary guiding. Alright, 34. I think we can do like this. And then we can do it like this. And caudal 4. Okay. Now it's better to have lateral view in 90 degree. Экран торчишь, Вахыт, пожалуйста. Нам бурдың ба?
Ал.
Бурдың ба?
Я басып бурып қойдым. 45 градус.
Окей. Енді бересіз, тағы бір система бар ма?
Бір система немеге болып қойдым. Нейромакс.
Қазір. Маған бүйтесіз, мен қазір мынаны алам. Мынау ой коннекторды жалғап бересіз. Қазір, бір секунд. Мынаны аласың. Так, раз. Мен қазір мынаны алам. Мынаны жалғап жіберсің. Just a second, we need to switch from 6 French coronary guiding to Sophia Plus, and I will put. Okay, it's okay. Now we switch from coronary guiding, and we took a Sophia Plus. Now I will switch for Kazakh language to explain the plan of the treatment for our colleagues from the TV channel. Науқас 67 жаста. Көзіне шағымдар пайда болғаннан кейін науқасты МРТ-ға жіберген. МРТ-да Абзал Қайрат алдында айтып өтті ғой. МРТ-да ол МРТ-ға жіберудің себебі көзін тексерген кезде бір көзі соқыр болған. Науқастың екінші көзінде ми симптомдарына сәйкес өзгерістер болған. Ол қандай симптомдар? Көздің жарты бөлігінің көрмеуі. Егер сондай симптомдар болатын болса, ол топикалық диагностика дейді. Пациентте миында міндетті түрде бір өзгеріс болуы мүмкін. Егер ол көздің өзінен болатын болса, оған тән өзгерістер бар, ал егер ол көздің емес мидың себебінен болатын болса, ол солайынан бір бөліктері квадрат болып немесе жартылай болып жоғалып кетеді. Сондықтан науқасты МРТ-ға жіберген. Әрине, науқаста егер бас ауруы болса, көз симптомдары болса, бірінші кезекте глаукоманы жоққа шығарады. Одан кейін глаукома анықталмағаннан кейін МРТ түсіріп, ары қарай невропатолог дәрігер қарайды, және нейрохирург қараған дұрыс, егер мида өзгерістер болса. Контраст. Біздің ангиографиясын жасадық. Ангиография жасаған кезде мидың екі жақ жарты шарында 3 аневризма анықталды. Соның қазір сол жағындағы 2 аневризмасына біз операция жасаймыз. Біздің жоспарымыз мына тұрған 2,5 сантиметрдей шариктің шығатын тамыр бар. Сол тамырға шығып, мидың тамырына қарай өтеміз. Өтіп болғаннан кейін мына жерде 1 миллиметрге жетпейтін түтік бар, катетер деп аталады. Сол катетер арқылы ана тамырға арнайы қан тамырын ағысын, қанның ағысын өзгертетін стенд бар. Сол стендті қоюға қазір жоспарлап отырмыз. Мынау түтіктің диаметрі 2,8 мм, мынау түтіктің диаметрі 2 мм, мынау түтіктің диаметрі 1 мм-ге жетпейді. Және оның ішінде осындай сым темір сияқты нәзік дүние бар, оны проводник деп атайды. Қазір біз рентген құрылғының көмегімен осы дүниенің барлығын ана аневризманың сыртына қарай алып баруға тырысамыз. Ал біз деп бастайық. Егер естіп тұрсаңыздар, фон сүре қосып қойғанбыз, ол Бақара сүресі. Біз 2 жылға таман дос сүрені қосып жүрміз. Операция кезінде еш алаңдатпайды. Және операцияның сәтті өтуіне өзінің себебін тигізеді. Okay. Yes, as usual we play Surah Baqarah. It's very helpful. Yes, I think in many places has many traditions. In some places I have seen the Bible inside the operating room. Also possible to put Quran, and we did our own improvement and we put the surah, and it's very helpful during the operation. We are doing nearly 70% of cases under local anesthesia, and during the local anesthesia it's very helpful for the patient to be more calm, and I think it's also helpful for the operating team. And now we put Neuromax a little bit high enough, and Sophia Plus now in cavernous segment. We put the AP view in a working projection. We can switch this one here, and to help for the navigation, this is 3D roadmap. We can put it here. I think you can see, I hope you can see. Yes, the guiding in the cavernous segment, Neuromax in cervical part, and we need to keep in mind that there is one more aneurysm at the entrance of the aneurysm, the bigger one. And without 3D, I think it's nearly impossible to control. Now 3D is moving, and I think in this case we need to go inside the aneurysm and then we can go outside. Bir айта өтетінім, мен операцияны ағылшын тілінде бастадым. Қазір операция параллельді YouTube-та жүріп жатыр, онлайн лайф режимде. Біз бұл тәжірибені бірнеше жыл болды жасап жатқанымызға. Ол дүние жүзінде осы операцияларды үйренем деген жас мамандарға арналып жасалған тактика. Және дүние жүзінде көп мемлекеттерде біздің операцияны қазір қарап отыр. Бір моментте 100-ден астам кісі қосылады. Әдетте демалыс күндері болғандықтан таңертең 20-30 адам қосылып қарайды. Құрама Штаттар бар, Австралия бар, оңтүстік Африка бар, Үндістан, Жапония, көптеген мемлекеттердің дәрігерлері осы операцияларды қарап, бізге кейін өздерінің ойларын қосымша айтып отырады. Қандай ойлары бар екен бөлісіп отырады. Біз енді өзіміздің жасап жатқан жұмысымызға сенімдіміз, сондықтан біз YouTube-та солай бөлісеміз. Smart mask. Бұл аневризма күрделі аневризмаға жатады, сондықтан операция сондай тез бола қоймайды. Мына ангиографиялық құрылғының бір басымдылығы ол екі проекцияда көрсетеді. Енді біздің дүниеміз трехмерный, үш өлшемде болғандықтан өте маңызды. On lateral view, it looks like I'm at the orifice of distal part, but on AP you can see that I'm quite distal from the orifice. That's why I will take my headway duo through the aneurysm. We should loop it inside the aneurysm, but one more problem. Okay, I think we're very close to the exit point. Just a second. Just a second. Yes, our colleagues from the TV channel now discussing the zero gravity system. It's very helpful for me to do the operation in comfortable condition, and the main point, the operating team should be in comfortable condition. It's the main key point. And I had a menisc rupture in 2018, and then we asked our administration to help to prevent the progress of the disease, and at that time Biotronic distributor in Kazakhstan started to provide zero gravity system in the country, and we were the hospital number 4 or 5 who get this gravity system. Yes, and it's very useful and very helpful. It prevents lumbar spine damage, and it prevents problem with knee. And I think I have seen many colleagues with the knee problems, and it's not so new and surprising. We especially took, yes, in this condition, maybe navigation with the Traxxas could be more smoothly, but okay, let's do it with the Sofia. Yes. The development of the stroke treatment is, I think, the key point in improvement of these devices, and nowadays we can navigate everything easier. As the distal Traxxas catheter is okay, but Sofia Plus, I think, is one of the catheters used mostly for the thrombectomies. Yes. Okay, let's do it like this. The point number 1, we need to straighten our catheters, but maybe we can place first of all the thread, and then we can straighten the artery. We have distal access catheter, then it should be easier. Okay. Thread perisons и гепарин бесныш. Now we are at the exit point of the aneurysm. The Sofia Plus is soft enough, that's why it's okay. I am doing very gentle injection of the contrast. We have seen from the stroke cases, in normal, even in normal anatomy, if you push the contrast in ICA with the distal access or aspiration catheter, It could be worse scenario. You can rupture the normal artery, not only diseased artery. Yeah? That's why it's very important. Біз қазір катетермен ортаңғы ми артериясына шықтық. Бағана операция алдында оны талқылаған болатынбыз. Қазір катетермен шыққаннан кейін біз екі катетермен қазір аневризманың шыға берісіне тұрмыз, итерер. Қазір ортаңғы ми артериясына өткен катетер арқылы біз арнайы түтікше стенд деп аталады, соны өткізіп жатырмыз. Бір техникалық қиындығы біздің катетеріміз аневризманың ішінде айналып өтуге мәжбүр болды, өйткені аневризманың анатомиясы сондай қолайлы емес. Қазір біз операцияны жалғастырамыз. Бұл осы әдістің артықшылығы, науқастың басын ашудың қажеті жоқ. Қазір біздің арнайы катетеріміз ортаңғы ми артериясына дейін өтті. Now we have Sophia inside the distal part of the ICA, and I hope we can straighten the course of the artery. I hope we can. Yes. Yes. Now the course is straightened, and then I think we need to reposition our headway. I think we don't need to cover the ICA orifice. That's why we will try to place our thread. It's a regular thread, it's not thread X, and it's a problem with the distributor company. I think the shifting from Terumo, from microvention for Terumo Nero, it's a little bit painful point for the company, and now we have only some limitation in the stents. Also, it's not a thread X, but it's okay. The delivery of this thread is quite smooth. Maybe we created some spasm because the Sophia Plus now straightened the course of ICA. That's why there is some stagnation, and now we can deliver the thread. I hope distal part is enough. It's nearly centimeter outside of the aneurysm. Okay. Now I will try to do it like this, and it's not open, huh? Okay. Let's try to go. Yes, because of this maneuver with straightening the course of the artery, the stent could twist it, but now we can see the stent is okay, and now I will little bit over open the stent and then we'll pull it. Yes. We need to keep in mind we have two aneurysms. The one is proximal, the smallest one, and the second is distal, the big one. Okay, let's do angiography. Yes, with the long stent, it's very important. Just a second, it's very important to keep your eyes on the distal segment and this delivery wire. Yes. Let's look like this. It's stagnating, and it's also possible to place coils, but I think one thread should be enough. I prefer thread in such a case. If we need to start at the level of ICA bifurcation, then we can start from M1 very proximal, and the distal part of the thread is usually stent, and then the FD portion is just starting. It's not opened. Mailed. It's a small problem. I think we need to increase the radiation level. Біз қазір стентті орналастырып бастадық. Стенттің басым бөлігі ашылды, бірақ мына төменгі бөлігі ашылатын кезде техникалық моменттері бар. Okay, I think we can open. Yes, now we open the stent, and I will pull my Sophia, and maybe we need the balloon to open the thread. Okay. Just a second. I think we need to take. Yes, this part is a little bit challenging. And I should pass this segment with the headway. It's a key point. The microcatheter is in the lumen, that's why it's better to push the headway and to pass the segment. It's okay. The Sophia is up. Yes, it's very important to keep the wire distal, to keep the access to the anatomy, and as you can see, we a little bit moved the thread inside the aneurysm. Okay, we have the wire inside, and let's do massage with ICA black. I need a. Yes, it's a 6 French. That's why I could not navigate the second device, and we should navigate this one. Okay. I hope we can. Yes, it's all the time risk of stent migration. Just a second, I need to check the circulation. Okay, let's check. Okay. ICOM should be present there. There is no PCOM on this side. but there is a washout of the contrast in ICA territory. Okay, let's see. I think it's very small icon. Yes, there is a icon. It should be icon. Not an easy aneurysm, not an easy anatomy, but let's continue. I will take a little bit more. I think it's better to take a balloon. Yes, it's better to take a balloon. We need just angioplasty the proximal segment. No need to go distally. Hyperglide balloon should be okay. Hyperglide 4-15 пересост. Now I need to leave my delivery wire inside and Төртеуін бес болса болды. Любой нашиваш. Yes, has the wire inside and I hope it will not move. It's very important. Yes, it's not moved. We need additional space for the balloon. Так, трехходовый краник пересосан. И шприц пятерку пересошь.
Пятерку здесь,
Yes, now I'm preparing the hyperglide balloon and yes, it's easy preparation than double lumen balloon. Арнайы баллон дайындап жатырмыз. Стендтің ашылмай қалған бөлігі бар, соны үрлеп ашу үшін жасалып жатқан әрекет. Екінші опция әрине басты ашып, тамыр қойып қосымша анастомоз деп аталады. Содан кейін артерияны жауып тастауға болады. Бірақ ол операцияда барлық кезде сондай нәтижесі әртүрлі болуы мүмкін. Теріс. Yes, the problem this stent is not thread X, it's the first. And the second is the length of the stent is quite long, but it's positive part, the long stent is needed, and now we prepare the balloon, and then the risk of migration is less. But if it's migrate, it's a disaster. Huh? I hope we can do it without any disastering the situation. I hope it will went inside. Yes, it went. Yes, the positive part of hyperglide, the profile of the stent of the balloon is low. Then the double lumen devices. That's why I hope the navigation will be more smooth. Okay. At this point I need to take out the delivery wire of the thread. I need to take out. Okay. Okay. Now the stand is placed, and there are 2 points. The point number one. We have a additional length of the. I don't know why there is a some friction in the system, maybe because of this tortuosity. We start to move the stand, but okay. I just need to place my hyper glide at the proximal point, and I need a little bit more, but let's do as much as possible. Okay, just a second. Yes, we deflated the balloon. That's also important. I place the balloon lower. Then we can go inside. Okay. Now I need to deflate the balloon. Yes, the stand is functional, but it's not fully opened. That's why we need to do this maneuver. Maybe the second flow diverter stand will be needed. We'll see. Maybe. I don't want to place the second one, but if it's needed, we can do it. Okay. I just need a small part of the balloon to be in touch with the FD. Yes, there is a lot of friction in the system. I don't know why. Okay. I will take back my Neuromox. I don't know why it's a lot of friction. Now it's better, but then I have no support. It went a little bit wrong. We need to go to the lumen. I hope we're inside the lumen. Okay. Then we can push both systems. It's a soft device. Huh? Okay. It's nearly impossible to push the... Okay. Okay. I will take back the Sophia. Then we will inflate the balloon. Yes, the stand is pushed. Stand is pushed, but it's not opened. There's a lot of friction in the system. Okay. Okay. Let's check the anatomy. Oh, it's working. It's not opened in the middle part. Bizde headway door жоқ, да? Бақыт. Headway door қалды ма? Okay, I think we need to take out the Sophia. Хорошо. The problem with the Sophia. Свет жаға салыңдар. Свет. Ой-ё. Так, су таусылып қалмасын, қарап қойыңдар. Yes, I'm informing the team that it should be enough saline in the system. Maybe at this point we need to change the balloon. Okay. Не бересаш, Бахт, септор. We will take a scepter balloon. Солнечный же терст. Так, я нажде траксис пар, траксис саш пересаш? Нажде траксис какой? Не. Ашер. Okay. Nobody said it will be easy. The aneurysmal sac placed main part of the FD inside the aneurysm, and in healing process it might be a little bit problem. As it's better to place coils, but after placing the coil, the visual deficit will be forever. From the Kilun company. Kilun is a company from our neighboring country. Oh, it's quite smooth navigation. I think in this point we need to inflate the balloon to control. Okay. There is a little bit air inside the system, might be, especially it's outside. Okay, it's not going inside the inside the stand. It's going outside. Okay, let's try to navigate the success distally. Okay. Yes, and hopefully it's under general anesthesia, and that's why this kind of maneuver is less, we need to less pay attention for the pain. Yes, it might be painful, but yes, the wire is going outside. Yes, goes outside. Okay, it goes outside. Okay, no, outside. It's outside of the stent. Yes, it's a possible scenario. Not good. It's outside. It's outside. Yes, it's a problem of long stents, huh? Okay. Narcos! Narcos!
Наркоз.
Yes, at one point the general anesthesia is finished. Yes, there is a problem with stent. Stent is not opened, and usually it should open, but it's a previous version of the thread, and it might be like this. Huh? Okay. We have two options. Option number one, we can retrieve the thread and we can place again FD. I think it's an ideal option. Yes. It goes outside. It's all the time goes outside. Yes, all this proximal tortuosity is not playing at our interest. Huh? It's not playing at our interest. It's all outside, huh? Need to go. It's outside. Yes, I think the probable scenario we can go. No, it's outside. The probable scenario, we need to retrieve the headway. There is a problem with the aortic arch. No problem. Okay. I think we're inside the stent, yeah? The one possible option, we are outside of the stent. That's why it's problem to move with the balloon, but it looks like it's very mobile, huh? Goes outside. We need to go on lateral view, we need to go to the left, but it goes to the right all the time. We're going outside. Goes outside, it goes outside, it goes outside. Okay. It's outside of the stand. It's not an easy, yeah? Observe. It's not an easy. Let's check the engine. Yes, might be we need to do the. Yes, on this image it looks like it's opened, huh? So, what do you think? Like this, like this. I think at this point the stand twisted. This point is stand twisted. Now we are inside the aneurysm. We inflate it inside the stand. It goes outside. Okay. One of the lumen inside. Yes, now we are inside. Okay. Have to push this to me. Yes, also we are pushing the stand, but it's not problem. It's a J-shaped wire and okay. Now stand fully inside the aneurysm. Okay. The distal part inside the aneurysm. Okay. Let's see. Let's see. Septum and now we pass the segment. Now it's okay. Huh? Option number one, we can leave it the proximal stand in this condition, and we can go with the headway. We can do okay. Okay. Bici, Y connector australiesisch. Все, Japan, Australia. Australia. Yes, it's a problem. Знаешь, Y connector жалуем за. Того писаш? Икнешь. Yes, it's. Okay. Okay, let's continue. Need to go with the balloon. There's no balloon in M1 segment. Okay, let's take a headway 27. Sophia abscissor. Abscissor. We don't need Sophia anymore. We'll navigate the headway. Headway 27 through the first stent, and yes, we made an angioplasty, and now it should be better. There is a lot of possible options to skin the cut. I think I'm correct. It's an idiom to skin the cat or skin the dog. Как говорят? Назад, назад. Now we will re-navigate the headway 27. Біздің стентіміз қазір позициясы өзгергендіктен біз екінші стенд қоюға мәжбүрміз. Сондықтан катетерімізді қайтадан артерияның ішіне енгізіп жатырмыз. Сыртына шығып It looks like we're outside of the... Okay, there is a shipping technique. When you have the first device, it's possible to move with the second one. It looks like we're outside of the stand. Now we're inside the stand. Okay. It's a better scenario. Okay. I think it's nothing possible to understand, but now we'll do angio. Yes, the proximal part of the stent in ICA, proximally in supraclinoid segment, at the edge of paraclinoid, and stent is fully opened, and now we will do straightening of the artery. I will place the balloon a little bit proximal. I will take the ICA from the system, and now we're inflating the balloon. Okay, I think it's enough. The balloon is not so properly prepped. It looks like it will not go, huh? the idea is to pull the stent to the artery. Second, we need the wire inside to see the shape. Okay. Okay. Yes, the headway is inside the aneurysm. Huh? Just a second. Okay, now headway is straightened. It's look like this, and distal part of the headway is distal in M1 segment. Okay. Let's deflate the balloon and then as this anatomy is more reliable. And Abzal, what will be the second stent? No, let's discuss which stent is better. Так, подожди. Yes, we have thread, the same length, the same size, and we have the Revo, but I think the thread is better. Now we can, okay, it was a 35 right and 4 caudal. Our patient little bit moved at the one point of the operation. Let's see. Гепарин какой, да? Yes, now we can see the distal ICA and we see the aneurysm also. There is a marker and okay. Which stent is better? It will be some step. Okay. Не наш пересаж, бах. Фред пошел нам, да? Yes, on пересаж, Fred. Yeah. We should play one more Fred. Все, ошиблись. The same size, the same length, the same diameter, 4.5 by 34. Okay. Bitiriyor.
Bitiriyor.
It went smoothly. Yes, it looks like we have good ACOM. It's a good sign. It's better to have a yes, it's all the time better to have a collateral circulation, huh? Dobrze. I left my wire for the assistance. It's like body wire. But only point could be the proximal ICA is a little bit stenotic. It could be an issue. It's okay, it's okay. I took out the balloon, but now my delivery wire is only in place. Okay, let's place from the... Okay, now I think it's better. It's unvisible now. There is angulation, that's why it's look like this. Yes, we open the circulation. There is a step, it might cause stenosis. Yes, it's again step. It's look like, yes, it's look like small step. There is option number 1. I will take out the wire. Then I can change a little bit the anatomy. If I will push my stent and headway, the anatomy will become okay. This looks like there is a stenosis, yeah? Okay, now it's better. Now we can take one stent inside another. I hope there is no stenosis, huh? That might be this transition zone. Okay, let's see. Professor Chikirge Saruhan presented one of the earliest cases with the 13 pipeline inside the cavernous part, and it was a new ICA with small tortuosity, but it was a good presentation of the flow diversion technique. Yeah? No. Okay. Okay, let's stay inside. Oh, it's not possible to pass. Okay, let's try second time with the balloon. All the time problem with the pushing the balloon. Yes, we have a good possibility to recreate the situation Professor Saruhan had. Okay. Okay. Not bad. Okay. Situation number 2. We have one distal, one proximal, and now we need one in the middle. Huh?
Yeah, yeah.
That's why coiling may be the good option before the placing the flow diverter stance. Okay. Yes. Even now, it's not the worst scenario. It's a challenging scenario. There is a stand one like this, and we need to start inside the one stand and continue inside the second stand. And yes, for such kind of situation, yes, the option number 1 to prevent this is coiling, but coiling may cause the stable anokia. And the option number 2, it was a painting from Aster. Aster is a friend of Alice Conference, and it was a drawing from Aster. It's possible to place one inside another. Huh? It's not inside, huh? It's not inside. It's inside. It looks like, huh? I hope so. It will be better if it's inside. Yes. Now we have scenario number 3. Okay. And the worst part, there is a lot of metal. Huh? There is a lot of metal. Okay. We can measure. Just second. We can measure the length of the wire is 30.
30?
Yes, it's 30. We need something in between. Eh? We need the longest one. Kas не идет?
Черная динамичность.
Deriva Yes, it's a derivative form 525, yeah? Okay. Окей. Жоқ, біреу қойса жетеді. Біреу қойса жетеді қазір. Ана стенд былай тұр ғой. Бір жағынан кіріп, екінші жағынан былай қоя салу керек та. Okay, I will try to approximate two stands with the balloon, as we did in the first time, and then we can inflate with balloon the approximation part, and then we can place derivative of 4.525 ось нашей улицы. I will pull my balloon proximal. It's quite safe condition when you start in a bigger lumen and then you have a overinflation if the balloon is not properly prepped. There's no one stand inside another. I have this condition and I hope it will be stable one. Just a second, I need to push my wire distally. I will release the only point, it could be the stenosis between two stands. Let's see how it will be. Okay. No, I need to inflate the balloon and then it's possible to pull to straighten the headway. Now we should inflate. Where is my balloon? Okay, balloon is inflating now. Yes. Now you can see the balloon is fully inflated, and after that, yes, it's some issue with the preparation of the balloon. Okay. But it could be stenosis in this segment between two stands. Yeah? It could be additional manipulation and let's see. Just a second. We have a balloon in place, and we can inflate the balloon inside this construction. And let's see how it will be. Oh, it's like this. Yes. It's a very dense construction. I will keep my traxes distally, and then we can pull the balloon. Okay, let's do angioplasty here. And also we need to keep in mind there is a slight stenosis in the proximal part of the thread, which caused all this misunderstanding. Okay, now we can inflate again. Yes, now I think we can safely place our derivative stand. I'm deflating the scepter, and scepter is don't want to deflate. Yes, we need to deflate the scepter, and scepter is not deflating. Yes, it was a little bit mistake. I was asking for 415, but finally we have scepter 420, and the deflation time is a little bit longer. As now scepter is deflated, and let's check the stand here. I will do one more inflation. Yes, I think now stand is fully open, but there is a stenotic segment, and I think we can create a little bit spasm, and it should be no problem. So we have distally stand, proximally stand, and now we need to just connect these two stands. It's a kissing thread with the derivo inside. Okay, it's one more technique to kiss three stands.
French kiss.
No, it's Kazakh kiss. It's a Kazakh kissing technique. Okay, let's take the Revo 4.525, and I hope it will be without any technical issue. Usually we have a long stance, the Revo 40, 530, but this time it's only 20 and 25. It's a popular sizes. The giant aneurysms nowadays it's not so often. This balloon is not fully deflated. Yes, now the stand is in place. We need to deflate balloon, and we need to reposition it proximally. It's massaging the two stands. Kazakh massage. Kazakh massaging technique. Okay, I didn't expect so much problem. We had a similar case in Uzbekistan, and we did together an emergency hospital, and through the Nevian it was placed pipeline shield 4.5, I think it was at that time, and it was a very smooth procedure without any issue and problem. It's again starts not opening. No, not twisting. It's a stenotic point. It's a transition zone. There is an angulation, that's why it's looked like this. Okay, we can inflate after. It's not a huge problem. Yes, we can inflate distal portion, no problem. Now I need to retrieve my wire, maybe it's also cause some problem. Okay, and at this point I need to go this way. I couldn't. It's also problematic. I think. Yes, with Derivo it's a completely different situation. Just a second. Need to push delivery wire distally to keep the access. Okay, and the wire will be inside. Now let's go with the balloon. Okay, I need to check the receptor. As inflation and deflation of the scepter today is very strange. We tried it several times and it's a little bit not as usual. Okay. Тройка шприц пересаж. Maybe 3 cc inch. Тройка шприц. Saat kaç oldu? Yes, not all operations are the same. Some operations we should spend longer time, and because of the planets on the space, there is a retrograde 3 planets. It's a Mars and Venera, Virgo, and I think the Mercury is also retrograde. Yeah, Abzal. Ретроградные планеты. Okay, I hope at the end we will finish this case. Finally, we will succeed. Yes, now the scepter is arriving. Yes, and the construct is much more stable than before, but it's a problem of pushability. I could not push my plexus. That's a problem. Okay, now plexus is in place. Then we can go to the scepter. Yes, this nose is all the time problem. The nose of the balloon is all the time problem. Okay, now we can see balloon properly. It's now well prepared, and it's just a question of navigation. think we need to take out this construct. We took it out. The distal thread is located okay. We succeeded to the position. Distal. As the profile of this balloon is a little bit bigger than hyperglide, maybe we'll take hyperglide and can go with hyperglide. Okay. Sometimes it's possible to massage the stand with the wire, but let's see. Yes, we are thinking about the hyperglide also. Thank you, Maksat. Maksat is our colleague, neurosurgeon. It's one of the best fellow and student since residency time. Yes, let's take the hyperglide. Scepter is not want to succeed, but I think the hyperglide is not also good. It's kaput. Yes, hyperglide is kaput. But let's see. Maybe we can do something. Just a second. I have pain in my fingers because of all these maneuvers, and the procedure time is also a little bit extended. And just a second, I need this syringe. Yes, with hyperglide is easier. The preparation is easy, but the wire inside the system is not so reliable. It's too small. Yes, and once again I want to say thank you to Nader and the team of Pers Neuro, and I just arrived in the morning, and as I said yesterday, we are planning the live case. The conference went very well, and we really enjoyed the stay. In Dubai. Yes, we are preparing one more hyperglide, and there is so much friction inside. I think because the expedient is damaged. Let's see, maybe we can navigate it. Something happened with all these balloons. We couldn't push the scepter, we couldn't push the hyperglide. Yes, it's damaged. Now we need a new hyperglide. Басқасын берсінші?
Expedient аласыңыз ба?
Жоқ. Yes, we damaged the hyperglide. Бақыт! I have a spasm in my right hand. Okay, it's possible. It's not all the time easy. Hyperglide 4-15. Коробкасını көрсете салыңызшы. Бәрі 4-20 ма? Аша беріңіз 4-20. Okay, all hyperglides is 420. Аша беріңіз. 415 or 410 is navigation is more easier, but for 20 sometimes the navigation is a little bit problem. I don't know why. The 5 millimeter of the balloon gives less mobility. It makes the system rigid and okay, let's see. This is new Expedion, and there is a white torquer. It's a marker that it's a Expedion. It's a thinner wire. That's why we need to differentiate all these wires. I have a little bit spasm in my hand.
I can do.
It's a human factor, eh?
Yes.
All these movements, and now I have a little bit spasm in my right hand. Қимыл қозғалыстардың барлығы өте кішкентай болғаннан кейін, ана инструменттердің барлығы кішкентай болғандықтан бұлшықеттерге көп қысым түседі. Сондықтан мен қолым шамал спазм ұстап қалды. Бұлшықеттер тартылып. Қазір кету керек сәлден кейін. I don't know why. It's friction inside the Sophia today, as you saw in the morning, and the navigation of Hyperglide, the first one, was not so smooth, and now we have no Sophia, but there is a Neuromax. Neuromax is proximal to the tortuous point. That's why this tortuosity also takes mobility of the device. Okay, now the navigation is a little bit easier because the structure of the Revo is different than fret, but there is a lot of friction. Huh? Let's look like we're outside the system. Yes, it's for 20, that's why it's a little bit problematic. Okay, now I need to push my wire a little bit distally to make navigation easier. The J shape of the wire is very helpful. With the J shape, the navigation is easier. Huh? Okay, now the balloon should go. Проводник садишь. Проводник садишь. The Neuromax is now went to the external carotid, and there's a lot of friction in the system. Zoom research. Maximum. Yes, and now we could show you the positive part of the Hyperglide. Yes, it's much more navigable. We just need to pass the point of it's ruptured. Okay, we opened the stenotic point, and now I think it will be easier to go with the scepter. Okay, let's take scepter. Yes, it was a nice presentation from the colleague from Stuttgart. I'm so sorry I forgot the name, but after operation I will see the contact of our colleague, Islamic State in Stuttgart, and they had a good contact. As it was a presentation about the solitaire only in basilar stenosis. If there is a critical stenosis, it's possible to place the sonic microcatheter, solitaire AB device, and it's quite easy to control the possible thrombotic complication, and with solitaire, just placing solitaire in the basilar. By the time the stent has a radial force, it's a laser cut stent, and it's opening the way. And yes, we have some solitaire AB, and in some cases we started to place credo stent, credo 520, 420, 425, and we also see that the stent may open the stenosis without angioplasty. Yes, and many places the colleagues carry to do angioplasty in the basilar. It may cause complication. That's why this technique is giving some promise. I don't know why, but it doesn't want to go. I think it's at one point it's stucking. Okay, this point is inflated, but we need to go distally, and at distal part the balloons start stucking. I don't know why. Even we did the inflation predilation with the I don't know why it's stucking. Yes, the balloon doesn't want to go. I don't know why. Maybe now it will go. Okay. Okay, let's take ICA Black. Операцияның қазіргі этапында біз тарылып қалған стенттің бөлігінен өтіп, сол жерде арнайы баллонмен үрлеу керекпіз. Біздің мақсатымыз дәл осы этапта сол болып тұр. Қазір көреміз. Екінші өткізгішті алдық. Темір өткізгіш. Проводник деп аталады. Проводник талдық деп отыр. Ана жерде екі стенттің байланысқан жері, сондықтан сәл мәселе туындауы мүмкін. Барлық ситуация тамырдың қисықтығымен асқынып тұр. Бірақ біз 3 стенд орнатып, аневризманы толықтай стенттермен қамтыған болатынбыз. Осы кезеңде біз тарылып тұрған жерінен арнайы баллон деп аталатын құрылғымен өтіп тамырды үрлеу керекпіз. Yes, now it's coming. I think we had the problem with Neuromax. Neuromax is quite soft guiding catheter, and it's all the time trying to fall down and бір рет минус қоясың. Бір рет минус қоясың. Okay, now I hope we can push the I don't know why it's not going. Okay. We just need to shrink the distal part of the river, and it will go inside the first third. I don't know why it doesn't go. But only few millimeters. Okay. Let's inflate it again. It's also not possible to push the wire. I have problem to pushing the wire. Oh, yes, roadmap is what to say. Yes, now we quite distal, but not enough distal. Okay, we need just 3 mm. Сіздерге түсінікті болу үшін мына жерде стенттің тарылған жері бар. This point is stenotic. Our marker is here. We need our marker here. If it passes this point, then we can finish the case. And this roadmap is confusing. Okay. We need just a couple of millimeters. The proximal part looks it's going, but also we are pushing whole system. Huh? It's just a 2 millimeter. With this kind of tortuosity, it's not possible to push. This is a real problem, huh? I could not go. Maybe we can take Eclipse?
Yes.
Okay, let's take Eclipse. Let's take Eclipse. Eclipse biraz Sasha.
Eclipse aşağısı var. Bak.
I'm not sure it will work, but it's one more possible option to use. Ялтам биш. Каста брет итер корин, барса барда. There's a lot of friction in the system. Astrayus. Astrayus. Okay. This scepter was also for 20. It might be the one of the cause of this problem. Okay. Вақыт зиондар бар ма? Yeah. Не бересіңізші тағы бір Чикай Black. I will ask Chika Black. Okay, let's prepare the balloon number. Лақтырасың. Ой коннектор қалдырасың. Ол бітіш құттыш. It's damaged and I asked Abzal to throw the previous scepter with the Chikai. Yes, it's air, bubble air. Лақтырасың. Okay, this all is bubble. Now the contrast is arriving. We need to properly prepare the balloon. Ultrasound. Not an easy case, huh? Maybe bypass and the vessel occlusion could be alternative. Just 20 hours surgery and yes, maybe next time. Okay. Пятерку бери, Саша. Пятерка. Қолым ауырып кетті. Очкиімді түсіп кетіп отыр қайтады.
Бақыт апай?
Так, ой коннекторын бере сал. Так,
Может, сал что очки.
Зион емес, Чикай Black ашысың.
Очки не знаю. Зион керек.
Чикай Black ашысың.
Процесс так проследил.
Процесс пока проверишь. керек болып. Аша берер. Yes, maybe from the beginning the Revo could be the option number one. The Revo Silk Vista, but ну, керек жоқ. Пока мынау жетеді. Қоя салыңыз. Okay, we prepared the Eclipse, and Eclipse has a little bit shorter nose than нешеде басталды операция?
Отлично, блин.
Біраз уақыт оқыды. Қарным ашып кетті. Так, петличканың батарейкасы отырып қалған шығар жаңағы. Женя, у нас петличка работает? Окей. The microphone is machen. It's working. Yeah. And I have two microphones, one from our own system and the second microphone from the national TV channel, and I think it's quite stressful for the video team, but I hope it would be okay for the patient at the end. Okay, let's see. It's Eclipse, huh? We spent hours and hours to inflate the septer, and now Eclipse is inflated. I will pull back for the security. The back part is more safe. It's inside the aneurysm, and the risk of rupture is less. Yes, I think this point is better. Now we need to inflate the stent, and with little hope that stent will shrinken and will come back to the neck of the aneurysm. There is one thread is inside, and we don't need second thread, but even after inflation it's not properly open. Okay, let's inflate again. There is a stenosis. Unfortunately, this tortuosity is not allowed. Yes, it's a compliant balloon, but it's all the time some risk of damaging. Let's inflate. Yes, now far more better. And stent is opened, and we'll repeat the angioplasty. Maybe the Revo will come back. It's only hope. The shrinking of the Revo. It's very important to shrink the Revo. Yes, at this point. Yes, it's quite overinflation, but because of this stenosis, it's only hope the Revo will shrink the distal part. Usually it should shrink. It's very flexible stent. But when you want to shrink, it will never shrink. Also. Yes. there is angulation, that's why the situation like this. It fixed the angulation. That's why we are in this problematic condition.
Credo wants to be here.
Credo is better, but we have no credo on the shelf now.
Yeah.
Yes, it's a little bit problem. Okay, let's inflate this point. It's even overinflation, huh? It's overinflation. Okay, let's go back. It's better, it's far more better than before, but it's remaining stenosis, that's why we are continuing to manipulate. Let's only hope to shrink the real, and it's not shrinking, huh? It's not shrinking. Okay, let's use Chinese experience to keep inflating and waiting. Huh? The stent is opened in straight manner. It's not fit the curve, that's why it's look like this. But even now it's more than 2 millimeters, I think. Let's measure.
It's better than it was before.
Қазір мына жер тарылған азайды, бірақ дегенмен де мына жер әлі тарылып тұр. Бір 50%-ті тарылған жер бар, бірақ оны біз кеңейте алмай жатырмыз, өйткені стенд қабырғасына фиксация болып қалған. Сондықтан сәл қиындықтар туындатып жатыр. Okay, let's leave it like this. Okay, let's leave it like this. Let's measure.
Already measured. Dr. Maksat already measured.
Okay, it's already measured. Let's see how it is with the balloon. Баллон үрлеген кезде қаншалықты артыйда табылып тұрғанын көре салайық. 2-4 миллиметрге дейін үрленді. Ол бұрыш, ол мына жердегі бұрыш. 2-6 миллиметр ол жеткілікті диаметр, бірақ баллон жіберген кезде стенд қайтадан кішірейіп қалып отыр. 4 миллиметр болу керек, бірақ 4-тен аздау болып тұр. Шаршаған жоқсыздар ма? Операторлардан сұрап отыр, мана үстілеріне 10 килограммдық защита киіп алған ғой. Біздің Абзал Қайратович дәл сондай защитада тұр. The video operators from the TV channel now wearing the apron, and I'm just joking. Did they tired because Abzal is also wearing the same apron, and I know it's very uncomfortable to wear it, and at some point you start tiring. Huh? The point number 1, the point number 2 we covered with the 2 FD stents. We covered with 2 FD stents the choroidal segment, and I hope it will be without problem. Huh? Also, I hope it will be with no problem. Yes, at this time, yes, we're inflating balloon. It's keeping the diameter, but then it's deflating. The better way to place something like solitaire AB, or to place a credo stent. It's problem with the tender system. In a tender system, some instrument is not arriving, some instrument it's more than enough, and you could not control it till the agreement between companies is not existing. It's not shrinking. It's overinflated. Okay, till now we have 2.4 millimeter lumen. We placed 2 fret stands, long one and then one derivo stand inside, and derivo is starts from the PCOM segment, and okay, now it's in the guiding. I will take out a little bit blood. Yes, and yes, it's now quite enough diameter, and the aneurysm is completely thrombosed. I don't know it's good or it's bad, but the lumen of the artery is okay. We have a distal part opened and proximal is also opened. Could you show me the first image with the ophthalmic artery? Көз артериясын бір қарап шығайық. Ең басында операция. Вообще сонныйдан түсіргенім көрсете сол. Yes, we are working more than 1 hour, and stents are patent. It means the antiplatelet regimen is okay. The ticagrelor is working. It's a local ticagrelor. The name is Triventine, and Triventine is working. And now I hope we can finish this case. Yes, small stenosis. It's not a problem, but we should expect some intimal hyperplasia, and we will take this patient in a couple of months. Just a second, let's check the ophthalmic artery. I think it's coming from the external carotid, but it also could be absent from the beginning because of the amaurosis on this side before the operation. Okay, let's check. Yes, there is no feeling, and it wasn't at the beginning. Yeah? It was occluded, I think. Yes, now I will ask Abzal to do control CT. The brain looks normal. There is no delay in venous phase, and Abzal, let's do control CT. Okay. Yes, the ophthalmic was absent from the beginning. Maybe some small collaterals. Okay. Yes, we will give anticoagulation, Clexan 0.3 twice a day for 5 days, and then we will continue for Triventine for 1 year. And yes, there is ICA Aneurysm. Maybe we will take this patient in 1 month. Okay. Операциямыз бітейін деп жатыр. Қазір томография жасаймыз, миды қараймыз, содан кейін белгілі болады операцияның қалай өткен. Ойдағыдай болды. Тамырлардың бәрін қалпына келтірдік. Қазір сәл созылып кетті. бір стенд, басындағы стенд дұрыс ашылмады, сондықтан біз оны баллонмен үрлеп жатқан кезімізде стендіміз жылжып, аневризманың ішіне түсіп кетті да. Содан кейін біз екінші стенд қойдық. Екінші стендтің бізге жақын жағы қайтадан жылжып кетті. Содан кейін біз үшінші стендті аштық. Ақырында үш стендті жұмыс істеп тұр. Мына жерде егер қарасаңыздар, аневризма көрінбейді. Аневризма толық тромбоз болды. Және артерия өтіп тұр. Қазір томография жасаймыз. Одан кейін томография. Бұл құрылғылардың ең басымдылығы дәл осы аппаратпен томография жасай берсе болады. Бұрынғы құрылғыларда бұндай қызмет жоқ еді. Науқасты операциядан кейін каталкаға салып, операция КТ бөліміне тасымалдау керек еді. Одан кейін егер томография бір нашар нәрсе көрсететін болса, онда қайтадан операциялық бөлмеге келу керек. Бұл жерде басымдылығы біз көріп тұрмыз. Мынау ортасындағы контрастқа толы ол аневризманың өзі. Және мына жерде сіздер көріп тұрған стендтер. Ақырында үш стенд қойылды. Мен ойымша бұл аневризмаға дәл осы сценарий өте жақсы болу керек. Өйткені аневризманың жыртылу қаупі өте жоғары. Стенд қойса да жыртылу қаупі өте жоғары болды. Енді үш стендтен кейін жыртылу қаупі күрт төмендеді. Жақсы, барып шай ішейік.
Шаршадыңыздар ма деп бізден
жоқ, біз
сұрай бердіңіздер, сіздер шаршадыңыздар.
шай ішейік. Let's drink some tea. Okay, dear colleagues, you see the CT is clear, and I just had a conversation with our V channel, and everything is okay. The CT looks normal, and in 30 minutes we will start second case. See you in 30 minutes. Thank you. See you.